All right, we have folks trickling in. Welcome, everyone. We'll just wait a few seconds and get started. Thank you all so much for being here today. Hi, Dr. Moses. All right.
Hi, how's it going?
Good, good. Thank you so much for joining us.
All right,
All
thank
right,
you.
I think we're good to go.
All
Let's
right.
get started for today. Good afternoon, everyone. Hope you're doing well and had a nice weekend. And depending on where you're joining from, I know it's a little cooler on the East Coast today, so we're hoping we're off to a good start. So welcome to the Whole Child Care. Um, Family-centered care lessons learned from the New Jersey Integrated Care for Kids model. This is actually part one of a two-part webinar hosted by the New Jersey chapter, American Academy of Pediatrics. My name is Aditi Doshi, Senior Program Manager at the NJAAP, and I will be helping to moderate today's webinar. So before we get started, I'd like to note that today's session will last approximately 1 hour and all attendees will be muted to minimize any disruptions. If you do have any questions, however, please feel free to submit them through the Q&A box located on the control panel at the top or bottom of your screen. Today's webinar is being recorded, and we already got questions for slides, presentation slides, along with the recording will be provided post-webinar and will also be posted on our NJ Inc. website. Feel free to check that out at www.njinc.org. Today, our presenters have no financial disclosures or conflicts of interest with the material presented in this webinar. So today's session, we'll be hearing from three speakers. Welcome again, and thank you so much for joining us today. First, we'll have Dr. Steve Carries, who is a pediatrician and is the principal investigator of NJ Inc. He's going to provide an overview. Again, this is part one of a two-part series, so it's really a high-level overview and the current status of the program, as well as some lessons learned, followed by Garima Jain, who is a family support specialist for NJ Inc. through the Children and Family Health Institute Visiting Nurse Association of Central Jersey and the statewide Parent Advocacy Network. She'll be providing us more of an example on some lived experiences, patient and family, throughout the project with relation to the NJ Inc. Advanced Care Management Team and the supports that team provided throughout the program. And then we'll end with Dr. Moses, who is a pediatrician, and he's also one of our esteemed physician champions of NJ Inc., always on our clinical subcommittee calls. And he'll be discussing the successes and barriers of the NJ Inc. program from a pediatric practice lens. So we wanted to provide, a little bit of a viewpoint on all three different aspects of the program. And the remainder of the session will be dedicated to some Q&A. We did receive a few questions throughout the registration as well, so we'll try to adhere to as many as we can get to. But just in case we don't get through them all, we're happy to respond directly to the folks that sent in the questions at a later date. All right, and with that, I'm going to pass it over to you, Dr. Carries, and let me know if you need anything else, okay? You may be on mute, Dr. Carries.
Yeah, thank you, Aditi, for
No problem.
thanks. So thank you all for joining. This is our first of two to try to explain this very ambitious, somewhat aspirational vision to provide better care towards Medicaid children with complex issues. The model really comes from the federal government. It's a model that was developed by the Centers for Medicaid and Medicare Innovation. And the vision was to not just provide better care, but to integrate that care across all the various players that take care of families that have children with special health care needs. Go to the next slide. Okay, and the next slide. So this is a national model, and a total of actually 8 other states participated originally in this model. Several left early. The 7-year grant that started just before COVID hit So we had the distinct disadvantage of having the first few years occur while the COVID epidemic was going full force. But you can see the various states that have been involved with this project, and we've been able to meet and work with all of them. It's a model that affects all children covered by Medicaid, 0 to 20, and for New Jersey, the pilot area was Monmouth and Ocean County. So that's where the project took place. There's about 140,000 Medicaid children that reside in Monmouth and Ocean County. Next slide. We had a lot of help with this project. The grant was given to Hackensack Meridian Health, but we were full partners with the Visiting Nurse Association and with the New Jersey Healthcare Quality Institute. And we also worked closely with the Central Jersey Consortium, who helped us with evaluation, and with the New Jersey AAP, who helped us connect with some of the providers and work with its practices. And Medicaid was a formal partner of this from the beginning. We did this completely with the support of the New Jersey Medicaid folks, New Jersey Family Care. And as I said, the goal was not just to provide more wraparound services, more comprehensive care towards families that had complex kids in their care, but to integrate that care, because we know that these kids have a lot of different people working with them, the schools, sometimes the CMOs, sometimes other agencies that are community-based. And one of the issues, not just in New Jersey, but everywhere, is that much of this is siloed, so that all these various folks are working with the family, but not really connecting together. Families are often kind of left trying to figure out, where to go and who to use and how to work with the various help that they do get. So again, this project was a combination of increasing the kind of care given to families, but also making sure that care was integrated and people were working together to support the families in their care. Next slide. So here, this was New Jersey. Every state had a different design. This was New Jersey's design. Again, we had 140,000 children that we were theoretically responsible for. But our goal, based on the grant, was to only work with those children that had complex needs. So we had to decide what that meant, and then we had to figure out how to actually reach out and connect with those families. So the definition of complexity needed both a medical complex need, some social complexities, and also some behavioral complexity. So it was a combination of all three. Those children that had very little complexity, they were called SIL1s, and we could provide them with some support, but not the support of the care team that was going to work with the more complex needs. The level 2 and level 3 kids were the kids that had the real risk, and the level 3 kids had the highest risk. Looking at some of the data from around the country, we considered that probably about 7% of the 140,000 children in Monmouth and Ocean County would rise to the level of being SIL 2 or 3 children, and rise to the level of being able to take advantage of the advanced care management team that we organized to work specifically with those families. So we did this in a number of ways. We used Medicaid data, claims data, to have a decent sense of their medical complexity, and then we developed our own needs assessment. We called it the health story, to try to hone in on the social and behavioral needs of those families. Next slide. This is a complicated slide, but just to, again, show you the model. Again, we had to have a way to define medical complexity and social complexity. Medical complexity, as I stated, was based heavily on Medicaid claims data, where we could take a look at what their diseases were, what their conditions were. They're getting PT, OT, the various ways that Medicaid was supporting them. And we could define them based on having chronic disease that was not complex, for example, an epilepsy that was well managed, compared to a child with a chronic disease that involved more than one body system, that was had many claims working with them that were progressive or quite severe. So that was how we defined medical complexity using claims data. And then we used our health story to try to understand better their social complexities, their ability, their transportation, housing, educational needs, their insurance aspects, their involvement with criminal justice, homelessness, etc. You can see the list of various categories that would go into a social needs assessment. Next slide. And then having determine which kids would benefit from the advanced care management, we then wanted to make sure, as I said, it was integrated, that it worked well, and that the primary care home stayed the primary care home and stayed the patient-centered medical home, so that everything we did was aimed to support and sustain and grow the ability of the primary care doctors to provide this extended care towards families that were already in their care. So again, it was integrating the community services that we were going to be organizing, the educational services with the medical home, with the primary care providers in Monmouth and Ocean County. So it meant clearly, as I said, understanding all those needs ahead of time, trying to get a good sense, a more comprehensive sense, and really what we call a two-generational sense, because the issues of kids with complex needs is compounded when their parents are having issues, when the family is having problems. So looking at this in its total complexity is really critical for us in order to be able to provide this kind of services. And our goal was to offer more support and services. The hope was that if we did this, not only would we optimize the care of those children, increase their health, their well-being, increase family functioning, but also, again, this is obviously important to Medicaid, have less ED visits, have less inpatient visits, have less out-of-home placements, have better well child care, and more efficient screening for conditions. Those were some of the evaluations that we were undertaking. So again, in New Jersey, our goal was to use what we call care integration managers. These were paid for by the grant and were housed at the VNA in Central New Jersey, so that as these assessments were being done and the health stories were being organized, that these care integration managers would meet with the families, work with them, get a better sense of what their needs were, understand who else was providing services for them, what other community agencies were involved in their care, and then help develop a care plan that met their needs. This was basically a shared decision model, so the families were involved from the beginning in defining what they thought were their critical needs, the needs that needed to be addressed by our teams. And then we would sit down and work out a care plan for doing that. And then we would have the care management team, which includes community health workers, family support people, child life people, social workers, then actually perform the actual care management processes with the families, always getting back to the pediatricians to have them be a part of the process from the beginning. Next slide. So again, looks something like this. So the team that would be assigned to the families would be sometimes just a community health worker. Sometimes it might be more than one person. Child life, we found, was extremely important, particularly for the older kids, and also for working with the other people in the family. The other kids in the family, for example, are often neglected when a child with complex needs kind of overwhelms the family structure. We had intake coordinators that we organized to help the CIMs to make sure the health story was done. The health story was complicated. It was about 63 questions, a lot for a family to deal with. Although they could do it on their smartphone or their computer, they could do it over time. But for a lot of families, we found that getting the health story done was a rate limiting factor. A lot of families just thought it was more than they could handle. And that's why we started using our care integration managers and our intake coordinators to help the families complete the health story. Our goal was to get more people involved, not to have barriers to getting children to get the care that we thought we could provide them. And over time, I think we did better and better by getting more and more families to actually get their health story done. And we worked heavily with the AAP to reach out to pediatricians in both counties to let them know what InCK was, to talk to them about how to get their families to be involved. There was a little short form that they filled out called the do form that gave us all the information that we needed to be able to contact the families. Because one of our barriers from the beginning was finding where these kids were and how to contact them. So working with the primary care doctors, working with the schools, working with the community agencies, we had a variety of approaches that we used to try to have access to potential families, have them understand what we had to offer, and have them take the first step into trying to complete the health story. Next slide. We also had and developed a partnership council, again, in this vision of having integrated care. We wanted to make sure that the community agencies knew about InCK and were heavily involved in it, not just involved in hearing about what was happening, but being involved in helping to bring in their ideas and thoughts and to try to integrate what they were doing with what we were doing with the families. So we developed a partnership council that was met on a regular basis, still continues. The goal was to have any agency involved with daycare, education, housing, food, schools, Title V agencies, child and welfare, behavioral health agencies, mobile response, juvenile justice, legal services, to have those folks meet together to talk about what we're doing, to talk with each other about what they were doing, and to try to learn how to develop a community-based system that worked better, that coordinated, that shared, that had some common values and goals. And that's been a very, very successful part of InCK. We also had a subcommittee of just physicians who met with us, again, to give us feedback about what was working, what was not working, or what we could do better. Again, the goal was to have this be part of the way that the practices worked. As part of the model, we had an alternative payment model, dollars from Medicaid that actually paid for the care management process, but also had some money for the physicians if they would actually do the assessments, do the health story. There was at least a small amount of reimbursement to them for helping to support this particular project. Next slide. So again, this is a pictorial picture of what the hope was. Again, the child and family are at the center of all this. Everything we're doing is for them. And then the shared plan of care worked out with the care integration managers to organize the plans for that particular period of time. And then connecting all these various agencies together to support the family, work together. The care integration managers would connect with many of these agencies to make sure they knew what we were doing. Sometimes one of the agency was already doing, everything that the family needed, and they became the care integration manager for that family. Our goal was not to disrupt what was in place, but to complement and supplement what the community was providing. Next slide. So we've learned a lot in these 7 years. I think, as I stated earlier, the first two or 3 years were complicated by COVID, but then we eventually got off the ground. We find that there are a tremendous amount of silos in the way we provide care, that the pediatric practice, as Dr. Moses will talk about, is is overwhelmed with seeing 25, 30 people a day and doesn't have the capacity, even if they would like to be able to connect with the community agencies, to work with their families, to work with their social needs and their behavioral needs, etc. We found, for example, and I think Armina will talk about it more, that many of the issues with helping a child with complex needs get to improve their status is getting the parents to be able to handle the situation better. If the parents have tremendous needs themselves, if they have barriers, if they have mental health issues, if they have their own health issues, there's no way they can help their kids if they're overwhelmed themselves. And much of what we did, I think, was trying to work with the whole family unit to improve their ability to function, to improve the family status. And then we have been able to connect with a number of kids, not as many as we hoped we would, but we've certainly connected with into the thousands of kids. We did one study of 600 kids that we worked with, and even in a short period of time of 1 year, we showed that we could save $2 million in reduced visits to the ED and to the hospital. And to the hospital. We also found that the families greatly appreciated the care and support. It was really well received. They felt like that we were a lifeline to many of them who were just drowning in the various issues that their child presented with as they were going through their own issues. Very hard for many families to work with the school system, for example, to work with some of the other agencies that have a lot of demands on their life. Next slide. So here's some of the numbers of kids that we saw, health stories that were done. So we're still this grant is still going strong. We're hoping to see enroll kids through the end of August. So if there are people out there that have kids in need, we're more than happy to connect with you and to try to reach out to additional kids until the grant runs out at the end of December. Next slide. There is a future. We think InCK dies at the end of December, and as you know, with all the Medicaid cutbacks, every state, including New Jersey, is just trying to figure out how to keep the number of families they're serving to continue to have some insurance. So that's their primary attention for this next period of time. But there is a new model coming out in the fall called Aspire. It takes what InCK does, I think, and it expands it even further. We're hoping that we can latch on to that and to provide some additional support for longer periods of time. Also, there's in New Jersey a palliative care model that's coming out, and we think at least some of the kids we're currently serving can be continued to be served through the palliative care approach. But well, that's more to come with that over the course of the next several months. Next slide. So I'm
Thank
sorry.
you.
Go ahead, Aditi. Sorry.
No, thank you, Dr. Carries. I just wanted to say, like, this is, again, it's a high-level overview, but I think part 2 of the webinar will also provide a little bit more detail. But thank you so much for your portion of the presentation. And I'd like to turn it over now to Garima. We're going to talk a little bit more about the family's journey throughout the model. So Garima, if you can just unmute, that would be great. Thank you.
Great. Thank you, Aditi. You can hear me well?
Yep, good to go.
Okay, good. So Dr. Carries provided an overview of the program, the numbers, but my presentation here will take you more inside the ACMT, inside the program. How does it work? How we've been doing it for the last couple of years, and a great team. So starting with family. So I'll be looking into showing you the family's journey into unknown territory, the deep emotional complexity beneath the surface, the compounding challenges families face in navigating this complex and fragmented healthcare system. The discussion will highlight the barriers and the burdens families face in navigating this complex landscape of care. So that's where I will highlight the NJAAP model, how this was incepted with a vision which was solution-focused, family-centered, coordinated care to really help navigate this fragmented care system. Next, you'll get an insight into New Jersey's unique attributes, which makes this model unique. And the multidisciplinary team, which is an intentional creation, how this was achieved. Next, I'll be presenting a case scenario, a family story, where you will see the care coordination in action, the roles and responsibilities of the team. How do we work together to create the circle of care for our families? And finally, I'll be presenting the lessons learned from NJ Inc. in last couple of years, what actually is working and must be supported, and for the future, what can we do more? Next slide. So something doesn't feel right. This might sound like a simple statement, but it carries a deep emotional complexity beneath the surface. So, as you all know, parents know their child most intimately. What foods they like, what is their favorite color, what is their preferred toy, what comforts them. And parents don't need anything learned, they just do it by instinct. Yet, when comes a diagnosis, be it developmental or a medical complexity, a sudden and overwhelming shift happens. In that moment, the power somehow is taken away from the parents. They now rely on unknown professionals, like maybe multi-specialty doctors, school counselors, social workers, psychiatrists, and many more to tell them what happened to their child. And you can only imagine what parents feel, mixed emotions. It's denial at first, and then grief follows. Then comes confusion and fear of unknown. In these moments, what do we see? Parents feel helpless and disoriented, and a sudden shift in power happens. This is very difficult for the parents to do. We must also understand and acknowledge that these diagnoses comes in the form of very complex medical terminology, which is very difficult to interpret for parents. What do they feel? They feel both intimidating and deeply unsettling, who are already grieving. So what do we see? Finally, stepping into an unfamiliar journey where it is leading to unknown territories, where expectations are high, but the future seems very uncertain, right? Next slide. Let's look at some of the compounding challenges families face, the burdens and challenges they go through. So at that time, just imagine a child just recently got diagnosed with any developmental or a medical complexity, a diagnosis. What do the families face? They are at this time navigating the child's diagnosis by understanding the medical terminology. They are balancing caregiving responsibility and yet maintaining a full-time employment. As you know, taking care of a child and youth with the complexity is financial burden. So they have to maintain that. Now, if we add another challenge of being an immigrant family, these challenges are often compounded by limited access to the extended family support. Who could be there around just to give them emotional reassurance? Everything is going to be okay. Or at least help them with balancing their caregiving responsibilities. So in this time when the family is grieving, lack of these supports actually makes them feel more isolated. And it further intensifies their challenge. If we add another challenge of a language barrier, this further intensifies these challenges, adding an additional layer when accessing care, services, and critical information is harder. So what are we looking at? The family's responsibilities are increasing. In addition to this, the families are now gathering information, coordinating with different multiple organizations, agencies, and service providers to gather the services. That could be maybe speech therapy, occupational therapy. It could be ABA, and to name few. They might be going with multi-specialty doctors to make an appointment. So what's happening? The families are further, their challenges and responsibilities are increasing. Along with this, families, not to forget, they might be navigating the insurance coverage, what the approvals would look like, what the unexpected cost of the treatment would look like. And sometimes with the multi-specialty doctors, or even to take a basic diagnosis, it might be a long waiting list with service providers. That further intensifies the challenge. So what are we looking at? the families find themselves managing the numerous phone numbers, contacts, case managers across different systems for different services. So families very soon get overwhelmed and more confused as they navigate this fragmented system of care to reach individual agencies. And of course, remember, when we're doing this, families have to retell their story again and again from telling them what happened. I feel that it gets diluted in the process. And it's like the families feel frustrated, unheard, and they have to navigate this. And when I was compiling this list, actually, if I talk about this, I was there at this one point. I was an MBA coming and working and living my American dream, a very young mother, and my child got diagnosed. Even though I was educated, but still navigating the system was not easy. I was an immigrant at one point. I had no family support. But again, these challenges are lived, so I know. At that point, I found a great organization span, which kind of helped me become from a parent to a professional, from a consumer to care coordinator. That's where the responsibility lies also to become a voice for the other parents who really don't know how to navigate the system and become a support. And that's also why I came to NJ Inc. to really go ahead and look into recreate the way the care is delivered. Services exist, but the delivery matters. So whatever I couldn't get, we come here together and create that delivery model. Next slide. So NJ Inc. model, I think this was light at the end of the tunnel. And there are many reasons for that. So there are certain unique attributes of NJ Inc. which makes this model unique, and the work should be supported. So NJ Inc. for the first time acknowledged that parents and caregivers are not expected to know all what happened and describe. For that, the NJ Inc. provides them a health story assessment. This health story assessment helps identify the medical and the social complexities, including very basic like food, housing, education, to name few. So this needs assessment and identification is the crucial first step that drives the care coordination moving forward. We get amazed that every time families take this assessment, sometimes they're not even aware of one core issue, which is actually causing the other areas to be impacted. So this is a big change. We help identify the issues the families is facing with them with this assessment. Another unique attribute of NJ Inc. NJ Inc. assures that every referral is paid attention to, as it is not a referral, it's a family looking for help. So for that, NJ Inc. model includes the intake coordinators who act as the first point of contact for the referrals coming in. And every family is given access to the health story assessment irrespective of where they are in the journey. Because sometimes we don't know where they are. The assessment can help us bring a lot of things they even know and we don't even know. So once these intake coordinators launch the health assessments, it's done, it's completed, they make sure that they are given in the hands of a care integration manager. Care integration manager, as Dr. Carey's mentioned, the air traffic controller, these are just wonderful addition to a program where each family is given a dedicated case manager who not only supports in completing the health assessment in their preferred language and helps develop an individualized care plan, which is family driven, aligned with families' priorities. I want to highlight here health assessment in preferred language. A question not asked correctly or understood correctly will give us misinformation. These care integration managers help with that. So the family's needs are identified. And this individualized care plan, the family is invested. They are the ones who are developing this, so we get their commitment and follow through. Many times we say families are not following through because maybe somebody gave them the best plan on earth, which was not in line with their priorities. So care integration managers help do that. It's really, we see, it's like when the power was lost, when the child was diagnosed, now the families get their power back. They are leading how they want to help their child and improve their family unit. Care integration managers do that. The care integration managers don't even stop there. They take these completed health assessments and individualized care plans and give it to the child's doctor so that they are aware or what's happening in the child so that they can support them in the medical world, and this cross collaboration can start forming the circle of care. Another unique feature of NJ Inc., the health assessment actually helps us, as Dr. Carey's mentioned, the service integration level for families. When I put this in a simple terms, it basically helps us identify the severity of the needs each family has. So our service integration level 1 families are the ones who have low acuity needs. So, but that doesn't mean there's no need or they should not be supported. So what InCK does is that InCK connects these SIL1 families back to their primary care doctors. So at least they could continue to be supported, and if and their needs don't over time deteriorate to the point where there's much more need. InCK doesn't even stop there. We make sure that our SIL families are extended the opportunity of retaking the health assessment annually to assess if they are stable or anything changed, because our families with children with so many complex needs and so many determinants, anything little can change anything. So they are given an opportunity to take that and see, and we quickly can take hold of them from where they are in the journey. Our service integration level 2 and 3 families are the ones who get a dedicated multidisciplinary team, which is the care integration manager led by an LSW licensed social worker and a team of community health worker, family support specialists, and a certified life specialist. So families are now getting that circle of care. Instead of them accessing multiple organizations and professionals for supports and services, now they have a team. So that's a perfect segue. Next slide, Aditi. What does that team looks like? Multidisciplinary team-based coordination. So for the NJAAP Inc. model, this advanced care management team is a very intentional team created to solve this fragmentation of care system problem. As now it is one team, one point of contact from the enrollment till the discharge. So it is from start to finish. So what does an ACMT is? We have the ACMT is led by a licensed social worker that serves as an ACMT manager who play a central role in coordinating all the efforts across the team. They provide an oversight and guidance to all the CHWs and other members and communicate and bridge any communication gap between the care integration manager and other members. They facilitate monthly meetings to ensure that there's a structure and support and any challenges they have. So basically, they are the ones who are helping to go ahead and help them. Then we have the FSS, who is a part of the team, who really plays in support and helps with the education system. Then we have the certified life child specialist, who really is a professional that supports children and youth and families with their any complex and stress, anxiety, or any medical experiences. They can also provide the kind of like expecting what to happen, because our families go through a lot of medical procedures. They can help them prepare for the surgeries after. So if you look into it, this team is very intentional the way it's done. Next slide. So I want you to go ahead and present a case story. Aditi, we're running out of time. You good? Okay. So let me present to you a little case scenario that would actually help you understand what the advanced care management team in action looks like. So here's a family story. A 6-year-old Hispanic female enrolled in an NJAAP Inc. program, and based on the healthcare assessment, we identified she was a service integration level 3 with a complex medical profile, including benign paroxysmal positional vertigo due to bilateral vestibular disorder, unresponsive episodes, seizures, a migraine variant, receptive and expressive speech and language disorder, along with suspected dyslexia. The patient had an older sibling with autism who was orthopedically impaired. The sibling had behavioral challenges which required an out-of-school district placement. So we can see the caregiver was dealing with the other situation as well. A comprehensive health story assessment reveals significant social determinants affecting the family, including food insecurity, limited access to clothing, educational challenges, and barriers to community resources, as well as children's exposure to domestic violence. The mother, the caregiver, who was the primary caregiver for the 3 children, two with significant medical complexity, has been managing her own health issues. A recent incident occurred where the mother fainted at home and was hospitalized. She was later diagnosed with a blocked artery and underwent through a heart catheterization process for herself. The mother continues to seek support from the advanced care management team to help stabilize and manage the household needs. So see the needs that exist. So now I'm going to take you into a daily life of an advanced care management team. How does that look like? And each roles and responsibilities each member played, starting with care integration manager. The care integration manager, once the health story assessment was completed, engaged with the family to develop a family-driven, individualized care plan in their priorities. The immediate concern was identified. So SIM right away provided the domestic violence resources, including providing information regarding shelter services to address the mother's safety first. The care integration managers didn't stop there. They went to create care pathways and establish clear goals and objectives in the identified needs. They further coordinated the involvement of the advanced care management team, including community health worker, family support specialist, and a certified child life specialist. And finally, the managers send the completed health story assessment along with the individualized care plan to the child's physician to promote awareness and start that ongoing support for collaboration. Next, community health worker, what role did they play? They facilitated a closed loop referral to connect the families with essential resources, including food and housing, the food and clothing. They did a consistent monthly outreach and built that trusting relationship with the mother where a space safe was created, where the mother opened about her own health concerns. Community health worker provided emotional support, encouraged the self-care, and assisted in even scheduling the appointments and attending the appointments for the caregiver herself. So since we know the caregiver is not well, they will not be able to achieve the outcomes we want to achieve for our beneficiary. Further, CHW initiated the referral for the FSS and the certified child life specialist after that initial stabilization happened with food, housing. The other needs were addressed systematically. CHW as a bilingual provider remained the central point of contact and have been coordinated different services with the FSS as well as the community and helped with the Spanish translation and was a safe point for the mother. Next slide. So family support specialists. So family support specialists collaborated with the community health worker and to address the child's academic struggles and the denial for special education services. FSS educated the mothers on the parental rights in special education and drafted the formal IEP meeting request. Attended the IEP meeting with the child to just look for additional services, and also when the school was not cooperative, looking at procedural safeguard rights, looking into mediation to take to the next step. And while continuing this advocacy, the advocacy would also be since the child was at school bullied and there was a physical aggression which was not properly addressed. Along with that, this is crucial. The youth and children we serve, they have medical complex needs. So they have multi-specialty doctors. Each doctor might have a certain set of recommendation. We need to know that the child spends a great deal at school, and that great deal of time school spent, maybe this child has seizure. If there's a certain need, the medical treatment has to be done. An individualized healthcare plan, which FSS can help in collaboration with the school nurse and the child study team, is so crucial and can be life-saving. So this is something which is done. I just want to point something, just if we go back to last slide, Aditi. So that family support specialists and other things right now, you might see that, other programs have these services too. What is so unique that's happening here? I want to stress something very important. So yes, some organizations do have these different services housed in one, but again, parents have to make that connection individually for accessing those services. A perfect example. As an FSS, I would the other day told a mother, we need to have written communication, write a paper trail, create the letter. Very happy. I helped her even write that letter in Spanish. Very proud of my work. I was in the case conferencing with the community health worker, and I said, the letter is done. Mom has to just print and send the letter to school. Community health worker just pointed, but Garima, she doesn't have a printer. I'm working on transportation right now. She won't be able to go to the library also. I'm like, see, if this was the other parent who did not send the letter in, I would have thought she did not follow through. She could not. So what we brainstormed quickly as a team, community health worker said, send the letter to me. I'll print it up. I'll send it to the mother, drop it home. She will send to the child's school in the backpack. It was done. And what happened? In that, we were done. And in that, we were able to get the meeting done. So see, this is a circle of care I'm talking about. Next slide. Certified child life specialist, what it provided supported interventions, especially when you saw that during the medical event and the stress related situation. As you saw, the children witnessed the mother fainting at home. That significantly impacted children. What they were showing, separation difficulties, school refusal, frequent crying, and the anxiety of the whole unit actually further intensified. So what did the certified child life specialist did? They really helped them provide that emotional understanding, which helped reduce the fear and anxiety of the whole unit. Event in there, and everybody felt safe. They can go in person over the phone as requested. So finally, coming back to what lessons learned, what works well, and what can be improved. I would just say it's a great model. It's unique in a way, the way it's delivering the care. What works well, families are supported by a team-based care coordination. The team remains a single point of contact for resources, referrals, professional connections from enrollment until discharge. Families are followed up every month by a dedicated community health worker or other members to support. It's not a case management, it's a care coordination, which is actually aiming to develop the family's capacity to be able to do this on their own. But it's supported. Families are worked as a unit. They're not worked in silos where they have to retell their story again. It's a case conferencing that's happening where families can be supported, the caregiver is supported, and if the sibling needs help, we would be there. Another thing is that it's it should be that the medical doctors and the collaboration which we are seeing between the school, the community partners, and the medical professionals is actually giving that wraparound care for the families, which is really works well, and that's really, as Dr. Carey's mentioned, seeing the great outcome in our families. What can be improved? I believe that if the community health workers and other team members can have visit the home, and then if the population we serve, actually they have a literacy level of sometimes like a fifth grader. And when that happens, sometimes there's also difficulty for them to communicate. So if the team can really have an access and have a home visitation, that would be very helpful. Another thing, the team, there's also a trust issue. We do serve a lot of immigrant families. There are many layers to it. So we believe that if there could be a location for the InCK to be housed where the other family members can put the name to the face, it will be very helpful. So a location where the team could be reside and the families can come would be very helpful. And the last one is actually a little ambitious, but I would really say it because I've been a consumer and I really came here with the intent to create something different. If this health story could be condensed and if this could be offered in the doctor's offices by the doctors, so that's a perfect segue for Dr. Moses. If this could be offered in the home, in the visit in your office location and tell the families this is something which they do, it's like they will get access to so many good services. And the trust is already there. They know you as a doctor, anything coming you in would be like a recommendation. If this could happen, then families can benefit. We like to reach out more, serve more, so we can recreate the way the resources are there, but the way how the care is delivered. That's what we aim for.
Thank
Thank
you.
you.
Thank you so much, Garima. Thank you for providing that. This was just, one example in a case scenario of so many different families. We have a few to share, but I think we'll go ahead and go on to Dr. Moses, and then hopefully we can add a few more details in our second part as well. So Dr. Moses, I'm going to pass it over to you.
Hi, thank you. So pardon my voice, it's going to be fading in and out here. But so, when it comes to outpatient pediatrics, we have come to a time where there's so much that has been asked of pediatricians, and it's the numbers keep increasing of patients we have to see, but the time we have keeps shrinking. And you do not want to do a disservice to any child or any family by cutting the visit short. So you see, and a lot of kids gone are the days where a child just comes in and it's a well visit, or maybe they're just coming in for a fever. There's always 2, 3, 4, 5 different complaints that have to be addressed. There are different family stressors that we see that are not often so obvious that may be, beneath the surface. And another thing that we're seeing is referrals and outside services, it could take months before a child is able to access, a visit to a specialist, or, to be able to get further evaluation done if I have to refer them to someone. So it's become more difficult. So we basically need help to be able to address a lot of these issues, especially knowing that a lot of the issues that we're seeing perhaps exist not in front of us. There are a lot of issues that are happening at home, at school, at different areas that we don't usually get to see. Next slide, please. And that brings us to, why does this, model of the whole child care, like, why does it matter? And that's because children's health is shaped more than just a diagnosis, right? Their outcomes are influenced by so many things, social determinants of health, everything from housing stability and transportation, food insecurities, um, maternal, or let's say caregiver mental health, but I see a lot of it on the maternal side, even from the very day one, postpartum depression and different things like that. There are a lot of issues that exist that, we're not able to completely address, right? You have school support issues. A kid needs a 504 plan or an IEP. Those are things that we need to look at as well. A lot of different traumas, stress exposures, and the family's capacity to be able to navigate the what I would say complex systems that are out there. Even in school, I have so many people that struggle with getting extra help for their kids at school. They've made it so much more difficult, and these families come back to us, right, to help them navigate this. So we often see that a lot of these issues may exist, but we don't have the time to address it. We don't have the time to uncover it. And so I always feel like I'm always leaving my patients and my families underserved, because I feel like there's always so much more, that we can do. Next slide, please. And that's where NJN comes in. It's how has it helped our practice? How does it help pediatric practices? This gap of, me being able to connect to the family on a larger scale and to be able to understand those deeper issues that they may be experiencing, to be able to understand those issues that maybe I didn't have time to address, to be able to understand, hey, why does this kid keep coming back, 3, 4, 5 times every month for the same issue, and then before you know it, they connect them with NJ Inc. And you find out that maybe at home they have, some issues at home. Maybe there's mold in the home. Maybe there's something in their home setting. Or I had a family live in a motel one day and living in a homeless shelter the other day. So there are issues that the families may never even bring up to me up front. But with NJ Inc., it's able to bridge that gap to those issues that are not so obvious, behavioral health concerns, their social needs, the family priorities and goals. So this health story that, was being referred to before, it's basically a family being able to go through the questions and answer everything, but it's a structured way of me being able to look and get that whole picture of my patient and their family and understand that, wow, this is what's going on. It's not just a child walking in that this child is not speaking, because of some sort of delay. There are actually environmental factors in that home that may be affecting why the child may be, developmentally delayed. And that makes those routine well care visits a little bit more meaningful, a little bit more better. Next slide, please. So why does this help us? So for example, a parent may say, hey, my child is acting out, and missing appointments. And through the NJAAP program, we may learn that, hey, the parent lost access to transportation. That's why they missed their appointment. There is a time that I referred a patient to a psychiatric doctor, and I'm reading the notes, and it's like, call the family, no show, no show. Before I get upset, lo and behold, the family's been having transportation issues. There was a lot more behind why those appointments were missed. But that's something that is not so obvious to me. Or the family recently moved. Is a child struggling at school? The caregiver is overwhelmed. There are times when I have certain families where it's mom, dad, their 3 children, and they have 2 other families that are living with them. Those 2 other families are not my patients, but that is the situation at home that's now made maybe the child I'm seeing, a lot of the issues that I'm seeing may just be because of that home environment. But again, NJAAP is able to tease out all these things that are not so obvious, right? The food insecurities I talked about before, language barriers that may be affecting communication. That's something that, thankfully I speak, Spanish is one of the things. I speak Spanish, but I see how sometimes these families, they'll come to me. I had a family call literally right before this meeting. I got on the phone with them in Spanish and they said, "Hey, I refer them to an eye doctor because the kid has issues." The mom is telling me that she just called them and there's no one that speaks Spanish in the office. So she couldn't make the appointment. Right. This is a real issue literally right before I came on this call. So now after I hang up, I'm gonna call the office and make the appointment for her. So those are some of the barriers that we face, and NJ Inc. is able to help us, bridge that gap. Next slide, please. Um, and then we talk about the individualized care plans, the family-driven care model. So with NJ Inc., their team helps develop a beautiful model where they're able to identify the issues from a family standpoint and those priorities. And they obtain, right, the developmental evaluation, food transportation assistance, therapy supports, and there's that support that the family and caregivers need. Or areas where that they're able to really address, and it's a beautiful, I call a symbiotic relationship where I need them and they need us, to make this work well for the family. So it's like my job is really to kind of present the NJ Inc. program to the family, and then NJ Inc. takes it from there. So it's just so helpful where it's like things that maybe were difficult for a family being able to navigate the system, make appointments for therapies and things like that. NJ Inc. bridges that gap, and they're able to do some of these things that perhaps we weren't able to do before. Next slide, please. I knew we were coming up in time, so. And then some of the practical benefits, right, in an office setting, it makes my visits a little bit more efficient, right? I'm able to not even wait to ask. To ask the family what's going on. I already have my health story. I've read what's in there. I know what's going on. So I come in there and say, why don't we talk about your transportation issues? That's something that's been addressed. Well, I know this issue is going on because some of these families, they're more focused on their child and answering whatever questions that they bring it about the child, that all these other issues they never bring up, whether it's because of lack of time or sometimes maybe a family doesn't feel comfortable sharing it. But now that it's there, I'm able to address it. And that 15 minutes I have, I can kind of divvy it up and focus on areas that are more important to the family. And it also reduces duplication of efforts and also builds trust with families because now I know more about them. They know that I'm basically more aware of their situation as a whole, and I'm part of their family and part of their team, and we're basically all working for the betterment of the child on a whole. Next slide, please. And this is kind of just more of the same from the last slide. But it's basically instead of asking, what do I think this family needs? We should be asking what matters most to this family right now. And it builds just a strong relationship with these families, relationship with the practice team. And then the follow through and the long term outcomes is where we really see the benefit of NJ Inc. as a whole. It's not just a one and done, right? There's a lot of follow through that happens. And these kids tend to do a lot better with a program like the NJ Inc. because knowing that I have a support system there for myself as a family, for my child, is just more reassuring for these parents knowing that I can just pick up the phone, I can send an email and reach out to this program and they can help, navigate whatever issues that I have. And also because it's coming from a pediatrician, someone that they trust, it just makes the whole relationship just perfect. Next slide, please. Almost done. Now, let's talk real quick about the challenges. So, explaining what NJ Inc. is something that when I first started, I spent forever talking about it. But fast forward to now when I tell families about it, and I'm like, look, you're having issues. this is what is going on with your child. There's this great program that can really help kind of navigate all the hurdles and barriers that you're going to face as we're trying to provide, find therapy for your kid, reach out to the school for an IEP. A lot of these things are going to be difficult for you, for me, for us to work through. Here is the NJ Inc. Go to their website and just fill it. And I let them know ahead of time. It's going to be a long process, but it's something that's going to be beneficial. And usually I give 1 or 2 stories about patients that have used it and it has benefited them. So I feel like a lot of times when these families know it's something that's going to help them, they will take the time. Even though it takes them a while to get it done, they still take the time to get through it. And again, these families are already overwhelmed. I talked about the language barriers and then also saying, all right, who is this person? Who is this government NJ Inc. They hear NJ Inc. They think, oh, it's another government program like that's, especially if they've experienced other programs that has failed them in the past. It's hard spending more time to something that may or may not help. But I think the most important thing is it coming from me. I think it's how I package the product for them that gives them that extra step to say, you know what, this is someone that I trust to take care of my kid. This is something that may be beneficial to them. But it is challenging. But I think it's something that is was challenging in the beginning, but now it's become a little bit better. And then last slide. So basically, again, just to wrap it up, as a pediatrician, there's a lot of difficulties. We have staffing issues in the office, so the NJ Inc. model is just something that I didn't know that I needed until I became part of the program. And it's been amazing because I'm beginning to understand my families at a much more deeper level than I have previously. And it helps us practice, again, the whole model of understanding the whole child, family-centered care efficiently, and obviously improving care coordination between all parties involved. And I can talk for another 15 minutes, but let me stop. I see we're at 1 o'clock, but that's about it.
Thank you. Thank you so much, Dr. Moses. No, it really, I think it's in your voice, despite what you were completely clear, but I could hear like the care and love that you really provide your patients throughout. So I love that you mentioned that, it's that trust, and there is a lot of vaccine hesitancy as well and fear going about, but we've seen it in all walks of life, like you said, families dealing with, these government agencies and associations. So I do want to thank all of you. Thank you so much. I know we have one question in the chat. I just want to touch on really briefly. Dr. Carries, I thought maybe you could just enhance or elaborate a little bit about this, but what are some of the technology tools that were used by the team? A shared platform, electronic health system. I know we did have a few barriers regarding this that we're going to address in our second webinar regarding just the interoperability. But Dr. Carries, if you want to just touch a little bit, and then I'm happy to send Kristen a little bit more detail afterwards as well.
Yeah, we had a lot of ambitious ideas about IT. The ones that worked the best, I think, was having the ability for the families to do everything online or on their phone, both by connecting us. We had the chance for them to use a QR code to connect with us. The goal was to make it easy for them to access us and to use those same tools to fill out the health story, and then we help them with it also. So having things being electronic, we thought was going to be a big help for some families that were less literate with computers. It was not always so easy for them. We also had visions of having the sharing all this information with the doctors and the other community agencies electronically. That was much more difficult to get off the ground. We did put all the work that Carmina's team did onto a platform that could be shared, so all the care plans are shareable, was sent to the docs, etc. So I think we had some success, not as much as we wanted to, but we had some success.
Yeah, that's a very good summary, and again, happy to provide a little bit more detail. We also have a lot of information on our website, and this recording will be uploaded there as well. Dr. Moses, I did want to ask you a little. I know we're a little over, but there was one really good question that came in through the registration. And Garima, if you want to chime in just really briefly, but what are some approaches to best engage families with that mistrust? And I don't know if maybe you've dealt with this. I know Dr. Moses, you touched on it, but are there ways that you kind of gain that trust, and how do they then, with this experienced fragmented system, how do they then kind of how do you build that trust to then have them actually, either join the program or get the actual service that they need?
Yeah, so I think initially it was here's a piece of paper about NJ Inc. Go ahead and take care of it. But when I'm able to sit down with the family and actually explain the program to them and talk to them about it and the benefits of the program and say, hey, I have other patients that have been there, done that, and this is what it's done for them, it kind of lifts off them taking the card and just leaving it on their car seat and never looking at it again, because this is something that I'm offering to them. And then I think the other thing is, these families are coming with a problem, with an issue, with a barrier that they're facing, and you're coming to me for an answer. This is the answer I'm giving you as NJ Inc. So I think also having that expectation that this is what it is, right? It's a questionnaire. It says this, you're going to go to this website, you're going to fill it out. And I think also having a person to say, hey, like, someone is going to reach out to you, or here is someone that you can connect with to help you take care of it. Just laying that groundwork initially. Now, when that person does call, it's not, who are you and where are you calling from? Oh, this is what Dr. Moses talked about. And then the fact that when you're calling and talking to them, they're also saying, oh, Dr. Moses sent me this information. That is basically how the loop is closed. And now the family feels more comfortable. So I really feel like the onus is on our hands to basically remove that mistrust. And I think it's how I present it to them, that I feel like has kind of helped.
That's great. No, thank you, Dr.
Yeah.
Moses. And I think that you touched on that live person. And oftentimes, sometimes like a lot of this information sometimes goes into the abyss with technology these days. So I like that you mentioned like a live person is actually reaching out to them. Garima, any other things to touch on? Or I
I
think,
would just say one thing, Dr. Moses, we need more champion doctors like him. I mean, really, the passion
yes,
in his voice.
very
We at
true.
Inc. We have been trying so hard to really do it, but we need more Dr. Moses who can come in and just say, "Do it. This is like a vaccine. Just do it. It's necessary." You know what? It will be one. It's a great, great model which should be replicated. Should stay. So thank you, Dr. Moses. That's what I would say.
Thank
That
you.
trust. Okay.
Yes, thank you
Thank
so
you.
much, Garima. Thank you, everyone, for sharing your time and expertise with us today. And thank you for all the participants for joining. I know, sorry, we went a little bit over, but it was a great conversation. So I just want to mention, again, feel free to reach out to NJ Inc. at njaap.org for any other questions or comments. And we're happy to answer the other questions as well and email those folks back. But on behalf of the NJAAP and NJ Inc. team, a big thank you again to our presenters and all of you for joining today. And please note that information about part 2 of the webinar, as we kind of close up and transition into the next year after the NJ Inc. program kind of wraps up, we do want to speak a little bit about that transition time. So we'll stay tuned for that information, and we'll definitely share it soon. But thank you so much, Garima, Dr. Carries, and Dr. Moses, and have a great rest of your day, everyone. Stay safe, okay? Bye-bye.
Thank you. Bye.
Bye-bye.